we have at Ahmedabad from 13th to 16th of Feb. And we have with us our joint organizing secretary, Dr. Amit Gupta, and
recording in progress.
Past secretary of Diabetes India Congress in 2023 at Indore, Dr. Bharat Sami.
Right. So, Umaji, I think it is live. You can start.
It's a privilege to be able to welcome each of you today for of learning from ADA. We have very two eloquent speakers who have kindly agreed to not just share their learnings from ADA, but also to give us a sneak peek into their authority in the subject. To introduce the committee, our esteemed panel, and to welcome all of you today, I call upon Dr. Amit Gupta. Sir.
Umar, today we have Dr. Bansi Sabu sir with us, and today is Doctor's Day also. So I will request Dr. Bansi Sabu to do the honors. And we were missing him for last 2 days, and now I hand it over to Bansi sir.
So you want me to introduce? I mean,
first,
it's really great pleasure.
Yes. So, sir, you introduced.
So we'll be honored to have your welcome address, sir.
Welcome address as well as a Doctor's Day message for all the viewers.
So first of all, happy Doctor's Day to everyone. All those doctors who have joined from all across the country. I don't know, Harpreet, whether you know that today we celebrate in India 1st July, the National Doctor's Day. It is to remember the services given by the doctors for the community. Government of India has recognized this day as a Doctor's Day. So we call everyone Happy Doctor's Day. And I'm sure, you know, our first, the Chief Minister of West Bengal, we remember him, Dr. B.C. Roy, who was freedom fighter also, and he was a doctor also, and he was first Chief Minister of West Bengal after independence. So we dedicate this day for Dr. B.C. Roy on his birthday. And in India, the biggest medical award by Indian Medical Association is also on the name of Dr. B.C. Roy, which has been given by Government of India from President of India. Just to tell everyone, once again, Happy Doctor's Day. The idea of doing these learnings from American Diabetic Association. American Diabetic Association by Indian physician and diabetes community seen as one of the best scientific meeting. And it is always a cutting edge science which we learn from American Diabetic Association. It's not possible for many physicians from our country to go and attend. We have recorded lectures of American Diabetic Association, those who are already attending it or those who wants to do the virtual attendance of ADA program. But every year we want to do a program immediately after American Diabetic Association that what we learned, what is new in ADA. And as Uma had already told that we have two eminent speakers. Dr. Harpreet is from Indian origin. So we welcome you, sir, on this platform. Today it's early morning for you. And Amit is joint secretary who has, helped me, and he's actually designed the complete program. Bharat is very active member of Diabetes India, past organizing secretary of Diabetes India in 2013, an Indore meeting. In a central part of India, we could do first meeting of Diabetes India. It was grand successful. With these few words, I request Bharat to introduce our speaker and then to start the program. Over to Dr. Bharat.
Thank you, Bansi sir, for the kind words and the welcome note. A very happy National Doctors Day to all my dear friends who are here. Today, we are here for learnings from ADA. This is to delve into the science which took place few days back. And we are honored to have Dr. Harpreet Bajaj with us, who is from Canada. Sir is an endocrinologist, researcher, and a public health expert. He is based at Toronto. and he has various research which are published by various medical journals, focuses on prevention, remission, and management of type 2 diabetes. And we will be taking his knowledge, mixing and amalgamating it with what is new in ADA regarding the newly diagnosed type 2 diabetes mellitus focus of management in 2024. So we will be taking his insights into the topic, what was there in ADA for newly diagnosed patient. Uma, can I have the next slide for the next speaker? Our next speaker is Dr. Deena Shrestha. She is again endocrinologist from Nepal. She is founder of DRCC Diabetes Rehabilitation and Research Center. She is chief editor for the National Consensus Statement for Type 2 DM and Hypothyroidism. She practices at Norvik International Hospital, Kathmandu, and she will be talking today about the type 1 diabetes. What are the key learnings from ADA this year for the type 1 diabetes? So stay tuned. Just a housekeeping rule. We will be taking all the questions after both the speakers' session. So stay tuned for lots of learning. Over to you, Bajaj sir.
Thank you. Thank you, Dr. Bansi, Dr. Amit, and Dr. Bharat for the kind introduction and for inviting me to present this. Happy Doctors Day. I didn't know about the history of Happy Doctors Day in India. So Dr. Bansi, thanks for sharing that information with me. It's also Canada's Independence Day. So I should say Happy Canada Day is how we say it. And so that's also something that we celebrate and cherish here in Canada. So it's a day off for me today, and I'm happy to present on this topic for the day. Am I sharing the slides okay? You can see the slides?
Yes, sir.
Okay.
We can see the slide, but if you can go full screen mode.
Yes.
Yes, thank you.
Okay, thank you. So yeah, my focus is going to be on type 2 diabetes, especially newly diagnosed type 2 diabetes, and how maybe the management of diabetes has changed type 2 diabetes as we come to 2024, how we've done it historically, and what landmarks have we landed on that have changed our paradigm for diabetes management. Here's my disclosures. So I'm currently the chair of Diabetes Canada Guideline, and I don't take any endorsement, CME, or advising role with any pharma, but I've been given many CME lectures for many different organizations, and I'm happy to be here today. I do participate in research, some of which is discussed today in our lecture as well, and I'll point out the research that I've been involved with when we go through the insulin section. So here's the outline, how I've divided this talk into three. First of all, focus on the question of this glucocentricity versus multifactorial diabetes management. So whether just glucose average, A1C, or fasting glucose is what we should care about, or should we focus on multifactorial type 2 diabetes management, which includes not just A1C, but also other things like blood pressure and cholesterol. The second highlighting point would be glucocentricity versus preferential use of certain medications that have shown organ protective nature. So these, of course, include GLP-1 receptor agonists and SGLT2 inhibitors, which are glucose-lowering medications, but we now have clear data that they protect the cardiac against cardiac complications as well as against kidney complications as well. So should these be preferred in certain populations based on the guidelines now? And then I'll end the talk with some insulin story, especially around innovation to a once weekly option that will become available very soon in different parts of the world. One is available now as I speak today. It was just approved and is available in the pharmacies in Canada. Not yet in India, but in Canada, we have icodec already available in the pharmacies. So first of all, if we overall broadly define how we manage and treat type 2 diabetes, there's non-pharmacological management, which is basically lifestyle, which includes diet, exercise, and also some of the digital tools, some of the CGM measures that may help, continuous glucose monitoring devices that actually tell and educate and help learn for the patient themselves as to how different exercise or diet patterns affect their glucose. And I think that's important and has gained a lot of momentum lately. The others are, of course, medications, so insulin or non-insulin hypoglycemic agents. Now, what is more prevalent in India, and it is in Indian colors of the flag, which is biguanides, so metformin and its sister, which we don't use anymore, fenformin, and then thiazolidinediones like pioglitazone, rosiglitazone, or toglitazone. So these are insulin sensitizers, so they help insulin work better in the body and have been used for multiple decades for that reason in type 2 diabetes. Now, since I'm talking about cardio protection or renal protection, metformin has some data regarding cardiac protection, but it's only metformin that has conclusive data. None of the thiazolidinediones have any benefit shown on cardiac outcome trials. In fact, with rosiglitazone, if you remember about 15 years ago, there was a meta-analysis that was published which suggested that there may be increased risk of cardiac complications for treatment with rosiglitazone. Those cardiac complications increase was never proven, but that's been a question around this class. There's also this issue of congestive heart failure or fluid overload that happens with thiazolidinediones, both with pioglitazone and rosiglitazone as well. The other age-old medication class that we are familiar with is the insulin secretagogue class. So sulfonylureas like glyburide or glipizide or glimepiride or gliclazide, all of these are available as generic. They're cheap. They do lower the glucose very well, sometimes too much. They, of course, can cause hypoglycemia. But do they have any data to protect that they protect against kidney or cardiac complications? None at all. In fact, some data suggests that these may harm the cardiac event rates, but that's not conclusive either. But we can't say that they protect or reduce the chances of having heart attacks or strokes. So question to you, and I know that we don't have a polling, but I'll just ask this question, think through as I read the question. What do you think is the most important goal of type 2 diabetes management? Why do we treat diabetes? Is it to get to a A1C target, which may be 7% or 6.5% according to the guidelines? Or is it reduction of complications? Is it just to resolve symptoms of diabetes? Or is it only to minimize the risk of hypoglycemia or low sugar? Or is it durability of glycemic control? Now, all of these are important, you'll realize. But what do you think is the most important goal? Why do we treat diabetes, which is just a number in the blood? Why do we care about it? And I'm sure when you think about that deeply, you'll find that reduction of complications is why we treat diabetes, because we want people with diabetes not to lose those 15 years of life that was expected to be lost if somebody got diagnosed with type 2 diabetes. So here's Mr. Fernandez and his grave. He died of a heart attack just a few years ago, but with a nice A1C of 6.5%. Rest in peace, Mr. Fernandez. The idea here to show you this is to say that HbA1c is one tool in the toolbox and should not be the only tool. We should look beyond just looking at glucose-centric approach. In fact, complications of diabetes, if you classify them, you can classify them into macrovascular complications, which include myocardial infarction or heart attack or stroke or peripheral artery disease. Microvascular complications, which we know, retinopathy, nephropathy, and neuropathy. but also some non-classical complications which cannot be easily delineated into macro or macrovascular complications. So some of these complications include heart failure, dementia, NASH or NAFLD, erectile dysfunction, etc. as well. Now, I'll just focus on the macrovascular complication because none of the others would matter if the person is not alive, if they die from a heart attack or if they have a disabling stroke as such. So on macrovascular complications, how should we approach a patient with type 2 diabetes? I would take you to the STENO-2 trial, which was published originally in the early 2000s. This is a study which was done in Denmark in the Steno clinics. And what they did was has changed all the guidelines and the standards of care across the world since the Steno-2 was published. So what they did was multifactorial approach to type 2 diabetes management, not just glucose centric. So glycemic control is one part of it, but there's also management of dyslipidemia, platelet inhibition, aspirin, blood pressure control, and lifestyle modification. So all five kind of multifactorial approaches, what they did, what they recommended, and what they tested. And what did they find in the multifactorial approach risk reduction randomized trial is on your screens. You can see the hazard ratio of 0.41 in favor of that multifactorial intensive therapy versus just conventional therapy, which was at that time, just look at the glucose values and not necessarily reduce cholesterol or blood pressure to the goals that are recommended now. So that was 60% reduction in cumulative incidence of cardiovascular events. So that included MI, stroke, or cardiovascular death events. They've also recently, from Steno-2, published a 21-year follow-up of this study, which suggests that in this study, if you did intensive multifactorial approach, you would actually prevent one death in 4.8 years. So if you treated with multifactorial approach, one out of your 5 patients will live longer. And how much longer? About 8 years longer if we followed this approach. So this is what we should be doing in our clinic, is multifactorial approach. And that's what the guidelines also recommend. Here's Diabetes Canada guidelines as to multifactorial approach. We've come up with an acronym or an easy way to remember is ABCDEs. So A is for A1C or glucose control, B is for blood pressure, C is for cholesterol, C is for specific drugs, which include ACE inhibitor, ARB, statin, aspirin if indicated, SGLT2 or GLP-1 receptor agonists. E is for exercise and eating healthy, S is for screening for complications, and smoking cessation, as well as self-management as well. So if you look at ABC, which is A1C, blood pressure, or cholesterol, which one of this matters more is the next question that comes up. How do I reduce cardiac complications? Which one is the highest on the order? If you look at UK-PDS data, this is a stepwise study that was looked at in terms of selection of risk factors. What matters most for coronary artery disease or heart attacks is actually LDL cholesterol. So make sure that all people with type 2 diabetes, especially of South Asian origin, because heart attacks are so common, they should be on a LDL cholesterol lowering statin medication at a good dose, at least a moderate dose statin like atorvastatin 20 milligram or rosuvastatin 10 milligram. So that should be the minimum that should be given to every patient with type 2 diabetes. Second on the list is HDL cholesterol. Now, we don't have medications that increase the HDL cholesterol, the good cholesterol, but of course, exercise and eating healthy is part of it. And then we should also look at, of course, A1C, blood pressure, as well as smoking. Now, part of this is A1C, but it's not the most important risk factors. And why is it that we don't have very good evidence in terms of glucose control and just controlling the glucose levels, A1C, intensively while getting cardiac or mortality benefits? So this is a meta-analysis of different outcome trials looking at intensively lowering glucose versus standard of care glucose lowering, so lowering to 6 or 6.5% versus letting it be around 7.5%. You can see at the overall at the bottom of the forest plot, you can see the confidence intervals are wide. The odds ratio is 1.02 with on both sides of unity, and hence there's no benefit that has consistently been shown just with glucose lowering. I'm not saying glucose lowering is not important. Don't get me wrong. Glucose lowering is important for microvascular complication reduction. So it reduces the risk of kidney disease or eye disease and nerve damage that happens from diabetes, from glucose. But for heart attack and stroke or mortality, people dying from diabetes, it's not the most important risk factor. So we need to look at statins, blood pressure, aspirin to prevent those complications. And it also is not just glucose lowering, but how do you achieve that glucose lowering? Now we have newer medications that may do better in terms of glucose lowering, but also prevent heart attacks and strokes. So glucose-centric approach has failed to reduce mortality. But if I take you to my favorite Bollywood movie, which was Dilwale Dulhaniya Le Jayenge, Shah Rukh Khan in that movie famously said when he was asked that there are two ways that I can go about when I hit an intersection. One will be the right way. The right way may not seem easy at first, but that'll lead you to success, is what that means. And why am I bringing that up is because at this intersection, when we talk about failure or success, the glucocentric approach, just caring about glucose lowering with sulfonylureas, for example, using glyburide, glipizide, glycoside, or with thiazolidinediones, which is rosiglitazone or pioglitazone, has not shown benefit on cardiovascular complications. What has shown benefit, what has shown success is getting A, B, C, D, E's and the A through D. So getting that A1C to target using drugs that actually have proven cardiovascular and renal benefits. So if you look at the evolution of diabetes management after metformin, metformin should be the first drug in every patient with healthy behavior interventions. If we lived more than 2 decades ago, we would be using sulfonylurea and insulin. The problem is we were just focused on A1C at that time because that's what these medications do. Of course, insulin is necessary in some patients. There's no other medications that works sometimes. But then sulfonylurea should not be your second or go-to medication after metformin. Then we had between 2000 to 2014, the thiazolidinediones or TZDs and DPP-4 inhibitors like sitagliptin. Those medications reduce glucose without hypoglycemia, but they never showed any cardiorenal benefits. What has changed since 2015 and the era that we live in now, we have GLP-1 receptor agonists and SGLT2 inhibitors, which have proven MACE, heart failure, and CKD complication reduction. So that's what we know about these drugs, GLP-1 receptor agonists and SGLT2 inhibitors. It started with about 2015. There was the EMPA-REG outcome trial with empagliflozin. Then we had liraglutide trial, leader with GLP-1 receptor agonists. Both of them showed MACE reduction, which is heart attacks, strokes, and cardiovascular death reduction. And they've also shown benefit on heart failure outcomes. So SGLT2 inhibitors have had many heart failure trials that have been positive. And recently, a GLP-1 receptor agonist, semaglutide, which is once weekly injection, was shown in STEP-HFpEF trial. So in patients with preserved ejection fraction heart failure, that it increases the walkability of the patient, reduces the symptoms of the patients from heart failure, is what that trial showed. And that was discussed at the ADA just last week as well. With the CKD outcomes, we have SGLT2 inhibitor trials like EMPA-KIDNEY, dapagliflozin trial, DAPA-CKD, as well as a canagliflozin trial called Credence, which clearly showed benefit on preventing kidney disease outcomes as well. But GLP-1 receptor agonists, recently there was a trial which was also discussed at the ADA last week, which is called the FLOW trial. I was a participant in all these trials that I've mentioned, including the FLOW trial, as well as the SGLT2 inhibitor CKD trials as well. And what the FLOW trial with injectable semaglutide shows is that it actually reduces not just cardiac events or mortality, but also kidney complications and people needing to go on to dialysis. And so that's what is now the era that we live in. So we have to change our practice is what we need to do. We cannot continue to do what we used to do 20 years ago for patients with diabetes. It's time to move on to these medications that actually reduce heart attacks, reduce heart failure, and reduce the kidney disease complications as well. That's what these medications do in terms of protection. They don't just lower glucose, but they also reduce blood pressure. They have renal protection. They have weight loss effects and cardio protection as well. So those are the benefits of GLP-1 receptor agonists and SGLT2 inhibitors. It's not just one effect of glucose lowering, but they have all these other effects, and that's why they're preferred now in most of the guidelines when you talk about guidelines. So this is the ADA, the American Diabetes Association chart. It's very complicated. You can see a lot of boxes. Let me highlight a few parts of this guideline, right? So it says that glucose-lowering medications in people with type 2 diabetes, we should consider independent of what their A1C is or what their A1C target is. If patients have a history of ASCVD, which means they have a history of heart attack or stroke or peripheral artery disease, so if they've had any of the complications or previously, we should definitely go with a GLP-1 receptor agonist or an SGLT2 inhibitor to add and reduce their further complications. In addition, as you can see on the top part in the lower bullet, if they have indicators of high ASCVD risk, so if they're of advanced age, they've had diabetes for a long time, or if they have any of the other risk factors like LVH, left ventricular hypertrophy on the ECG, etc., then they should be offered and started on GLP-1 receptor agonists or SGLT2 inhibitors as well. So that's the American guideline. How about the European guideline? So this is the European Society of Cardiology guideline. So you can see kind of different arches at the top. The different arches are, they span the spectrum from low risk, which is in white, to extreme red. So low risk in white, then orange is moderate risk, high risk to very high risk, which is in dark red. And you can see on the top dome part, you have the GLP-1 receptor agonist or SGLT2 inhibitor as a class 1 recommendation for those in very high risk or even in high risk populations with and without diabetes. Whereas in the low risk, moderate risk, they recommend starting metformin, but in the very high risk or high risk, they recommend not just metformin, but also addition of a GLP-1 receptor agonist and SGLT2 inhibitor. That was with the ASCVD or risk factors for cardiac disease. Let's move on to the American Diabetes Association back and look at patients who have heart failure or CKD, in which heart failure or CKD predominates. That's on the right side of your screen. You can see in either with reduced ejection fraction, HFrEF, or preserved ejection fraction, HFpEF, or when CKD is there with the EGFR, estimated glomerular filtration rate of less than 60, and if the UACR, urinary albumin creatinine ratio, is at least 30, they recommend preferably using an SGLT2 inhibitor to reduce heart failure as well as CKD or kidney disease complication. or if SGLT2 inhibitor is not tolerated, we should add a GLP-1 receptor agonist in this population as well. So then this is what we should be thinking about when we are treating our patients. We want to protect them against these complications, and these medications are proven to reduce those complications and are now in the guidelines that we should follow in our clinics. Of course, there are some adverse effects and cautions or considerations for GLP-1 receptor agonists, which are listed here. Cost sometimes is a big barrier. I understand in India that may be a bigger barrier than even in Canada. But I understand that SGLT2 inhibitors, like dapagliflozin, for example, are available as generic medications. And so maybe those could be preferred if cost is a barrier to initiation of these medications. The other barriers are listed for SGLT2 inhibitors, genital mycotic infections, which is young fungal yeast infections, can happen even in young or old people. And in fungal infections, we can prescribe topical antifungal medications like clotrimazole, which can help with this if it happens. It happens in about 5% of women and maybe about 2% in men. Urinary tract infections, very low risk, but if somebody has a history of urinary tract infection, you have to be careful. There's also other considerations and very low risk of this, of some other complications that we need to watch out for. On the other hand, with GLP-1 receptor agonists on the left side of your screen, GI side effects is the most common side effect. But the good part is that these are temporary. So what we need during those temporary side effects, in about 10% to 15% of people, they have nausea, vomiting, diarrhea, some have constipation, is to make sure that they go through them without having to stop the medication. So if they have nausea, you can give them an anti-nausea medication. If they have constipation, you can give them a stool softener, etc. So those are the ways that we help them go through that temporary side effect period in those 10 to 15% of patients who have those side effects. So I'll move on from GLP-1 receptor agonists to insulin space. And insulin is important not just for type 1 diabetes, but also for type 2 diabetes, because insulin is needed when the glucose lowering is not there, despite using any other medication. We will also always need that insulin. And insulin has gone through a lot of innovation over the last 100 years or so. Insulin was discovered in Canada, in Toronto, in 1921, so more than 100 years ago, and a Nobel Prize was given to Canadians in 1923 as well. At that time, there were many problems with giving injections because of how it was manufactured. Then we had better insulin preparations like NPH insulin, which are even available to date as well, which were slightly better than the first developed insulin, but that still had a lot of hypoglycemia associated with it. Then we got glargine U100 as well as detamir insulins. These have less hypoglycemia rates compared to NPH. And then more recently, over the last 1 decade, we've actually had second generation basal insulin analogs like the glargine U300 or degludec insulin, which are better or improved glycemic control with less risk of hypoglycemia as well. Now, the problem with insulin, and I'm sure all of us encountered the same problems, whether in India or Canada, is it's cumbersome. It's burdensome for the patient to have to inject every day. Any of these injections, you will need to inject at least once a day or twice a day, etc. So now there's a new innovation that is happening, is actually happened in Canada already, because icodec is the first insulin that was launched in Canada, being the first country to launch it as well. So there's 2 once-weekly basal insulins that are in development and are going to be available to us in the near future. I said icodec. Icodec is on the right side. You can see it's a structure that actually binds to albumin. so that the insulin can last a whole week. It has already completed phase 3 program that I'll share with you some of the results. F-Cetora Alpha is undergoing phase 3 program right now. The first results of this phase 3 program will be shared at the European Diabetes Meeting in Spain in September. For those of you who are going there, please make sure to join us for those results as well. Here's the ICODEC program. So ICODEC has undergone 5 trials, as you can see on the top, onwards 1, 3, and 5. These trials were in insulin-naive type 2 diabetes people, so people who were on not insulin drugs, maybe oral drugs, maybe GLP-1 receptor agonists that were newly initiated on basal insulin. And then onwards 2 and 4 were in insulin-treated people with type 2 diabetes, so people who were already on insulin who were switching to ICODEC. And you can see on the bar graph at the bottom, the ICODEC is in blue, and the comparator, either glargine or degludec, is in the gray bar. And then the blue bar on the A1C is actually superior, better A1C reduction compared to the gray bar, and superiority was seen in onwards 1, 3, and 5, whereas onwards 2 and 4, there was non-inferiority. So once weekly injection, if anything, is similar or better on A1C lowering than a daily injection of insulin is what this shows, which is huge. And then at the bottom, what is a rare event is a hypoglycemia event. So level 2 or level 3 hypoglycemia. So those events that are less than 54 milligrams per deciliter are shown. And what you can appreciate is the blue is very tiny, and it's equivalent to the gray bar as well in each of these trials. So it leads to about the same rates of hypoglycemia, not more, and the level 2, level 3 hypoglycemia rates are less than 1 event per patient year in the insulin-naive people with type 2 diabetes is what you can take home from there. The other important thing in this is not just hemoglobin A1C and comparable safety in terms of hypoglycemia, but treatment satisfaction. That means people, our patients, will be, of course, more satisfied if they have to inject only once a week than every day. And that's what these two graphs show. Onwards 2 on the left, onwards 5 on the right. So those two trials with ICODEC show that the blue of ICODEC, the treatment satisfaction with having to take only 52 injections in a year versus 365 for the everyday insulin injections, was much better, much more satisfactory to the participants. And they actually showed in onwards 5, we showed that this ICODEC actually led to better adherence as well. So people with once a day injection or twice a day injection many times miss their injections. They don't want to take so many injections. So it led to better adherence as well. So I'll just summarize and hand it back to the chairs. What I've discussed is that prevention of diabetes complications is the most important goal of therapy, and we should keep that in mind, especially regarding macrovascular complications, MI, heart attack, stroke, and cardiovascular death. Multifactorial interventions, ABCDEs from the STENO-2 trial, and using drugs in diabetes, not just for the glucose lowering, but GLP-1 receptor agonists and SGLT2 inhibitors, which have proven benefits in different populations as such. And then if you need insulin, a more patient-friendly insulin would be a once-weekly shot rather than a once-daily shot, which has been proven to have superior or comparable A1C lowering with comparable safety and hypoglycemia as well. So thank you, and I'll stop sharing and pass it back on.
Thank you, Bajaj sir. Thank you for enlightening us in such a comprehensive manner about what should be our approach towards a newly diagnosed type 2 diabetes mellitus patient. Unfortunately, Dr. Deena is not able to join due to some emergency, but we will carry on with our discussions. And Dr. Bajaj is with us, and Dr. Bansi Sabu is also with us. So we will carry on with our discussions. And we have got quite a lot of questions for you, Dr. Bajaj sir. And I would like to take one by one. In between, I would like to take your insights on various other aspects related to type 2 diabetes mellitus management. One question is, Dr. Bajaj, can you share any innovative approach or technologies that are currently being used in Canada for management of newly diagnosed type 2 diabetes? How effective have these been in improving patient outcomes?
Thank you for that question, Dr. Bharat. CGM, or continuous glucose monitoring, is a technology that is being used more and more in type 2 diabetes. CGM is like driving a car. When we drive a car, we look at the speed of the car all the time. We don't say that we'll look at the speed only when we start driving or when we reach our destination. We have to keep looking at the speedometer all the time. It's like that for glucose as well, because glucose is not just fasting glucose or one time a day glucose that sometimes people check with their fingers. It's actually 24-hour is what we need to look at. And that's what these continuous glucose monitoring devices allow us to do. And I know some are available in India as well. Now, in Canada, initially, when these continuous glucose monitoring devices came, because we didn't have enough information or research into them, we used it mostly in type 1 diabetes because of the hypoglycemia risk. But now we are finding more and more that these are very helpful in type 2 diabetes and also in newly diagnosed type 2 diabetes. In fact, at LMC, which is the research center that I work at, we've done and published a recent research study called Immediate with the CGM device in people with type 2 diabetes who were not even on insulin. They were not using insulin. They were using oral drugs or GLP-1 receptor agonists. And we show that these devices themselves can act as a teacher. They can actually counsel patients on what happens to their glucose with certain kind of food or certain portion of food. How much roti do people eat? How much rice do people eat? That affects their glucose readings, and people can learn from it and actually change their behaviors and get better glycemic control. And one last thing I'll say about this also is Dr. Bansi Sabu is part of this international consensus, and I'm part of that as well. We met last year in Vienna, and we are going to meet again, or we met this year actually in Florence to look at this international consensus on CGM devices as to what should be the targets for that as well. So that's something that is for the future. The digital technology is being used a lot.
Thank you, sir. That brings us to the engagement. I will come to it later. I have a lot of questions about that also, but first handing it over to Uma for a short break.
Thank you, sir. Can I request the IT team to please play a video? We have a video that we need to, it will take about 2 minutes. Thank you.
iCan, your new continuous glucose monitoring system for all people with diabetes. Easy to apply and comfortable to wear. Real-time glucose monitoring, continuous 3-minute connectivity. Every time iCan. Forget about the unawareness of hypo and hyperglycemia and pain of finger pricks. Forget about interference from vitamin C. Forget about worries about water when you're bathing or even surfing. iCan is water resistant to 8 feet for 2 hours. iCan has a 15-day wear life. With iCan CGM app, you can check your blood glucose anytime and anywhere. With iCan Reach app, you can share your data with loved ones. iCan makes managing diabetes easier so that you can enjoy activities of daily living effortlessly. Set your own alerts for low and high glucose levels. No worries, even at bedtime. iCan provides real-life accuracy. iCan empowers you with self-management. Your choice, iCan. SanoCare, caring for love.
Thank you. Back to you, sir.
Thank you, Uma. And that is actually what Dr. Bajaj sir was talking about, CGM, how it is changing their lives, how it is making people engage with the caregiver and themselves. Now, sir, I have 2-3 questions regarding engagement, because engagement becomes an issue for newly diagnosed type 2 diabetes mellitus patients. And I have a question for you, that how can healthcare provider increase patient engagement and adherence to treatment plans for the newly diagnosed ones?
Gee. And that's the whole holy grail, right? Isn't it? That diabetes doctors, doctors in general, are busy and they don't spend too much time counseling or educating our patients. And so we have to rely on technologies like CGM, but also teams, diabetes education teams that are available to us. Those may be dietitians or nurses or pharmacists that can help as a team member to educate the patient as well. Now, some of us may have those diabetes education teams at our clinics or hospitals, or we may employ them, or we may have collaborations with them as well. I also understand that in India, there are many online kind of education tools that are available. In addition to CGM, you can have an online help with dietitian, and they can make your menu as to what to eat, etc. as well. So that might be a good way in India, where online technology is so much available, and people are on their phones all the time to help with the education as well.
Very true, sir. And actually, that is, engagement is the key for patients. Now, we have one question from Vemula Kasi Vishwanatham. He's asking about, if we initiate SGLT2 inhibitor to our patient and if due to UTI, we stop it, how can we restart it?
Yeah, it's an important question, right? So UTI is actually, there was initial studies that suggested that UTI risk may be increased with SGLT2 inhibitors, but it has not been proven conclusively that it increases the risk. We know that diabetes itself increases the risk of UTI as well. So keep that in mind. Patients with diabetes, because they're peeing out more glucose, they will have more risk of UTI or even fungal infections, yeast infections as well. And so how to reduce that risk? First of all, look at their glucose readings. Maybe they're eating too much carbohydrates, too much sugars. And what will happen if you use a SGLT2 inhibitor in that kind of patient, if their sugars are very high and they're eating too much carbohydrate, then the SGLT2 inhibitor has to perform a lot of work. It has to pee out, because that's the mechanism of action of the SGLT2 inhibitor, is a sodium glucose transporter. So it transports the glucose out of the urine, and hence it can increase the risk of UTI or fungus infection. So if the glucose readings are okay, they are around 8% with other drugs, and then you add an SGLT2 inhibitor, you'll have a much less risk of UTI in that patient as well. The other things that we should educate the patient about is cleanliness. And we talk about hygiene, and it's very important, especially in people with type 2 diabetes, to maybe wash their private parts with soap and water. Maybe if they are at risk of a UTI or fungal infection, maybe wash it with soap and water every time they go and urinate.
Thanks for the insight, sir. That are really practical tips which everyone should keep in mind while prescribing SGLT2 inhibitor to any patient. We have one more question from Kolkata, from Dr. Mrinal Kanti Guha. And he's asking, what's your experience on the use of bromocriptine and hydroxychloroquine?
Okay. So those are approved medications in US for diabetes, though they've not done great or big trials in terms of glucose lowering medications. Some of the studies show maybe a 0.3, 0.4% A1C reduction. But, my response to that would be the whole 20 minutes or so that I discussed and showed you the slides. Our goal should not be just a glucocentric approach. That's what we want to get rid of. Is we don't want just to look at the glucose. We want to look at the blood pressure, the cholesterol, and then getting to glucose targets with drugs that have proven cardiac or kidney benefits. That's what the goal should be.
Very
So,
true.
Dr. Bajaj, will it be also true for sulfonylurea use also? Because I agree for bromocriptine and for hydroxychloroquine, we don't have that big data. But what about the sulfonylurea, which reduces A1C significantly? I mean, yes, we don't have the CV data or kidney protection because it's widely used in India. And this year also in ADA, I'm seeing constantly one thing that, sulfonylurea talk is always there in ADA since last 10 years. This year it was debate in somehow, and why the glitazone is stopped. There was not a single talk on DPP4, while sulfonylurea was still there. So what is your take home for that? Because Indian markets, almost 80% of us are using it day and out.
Gee, and very insightful, of course, Banshiji. But if you remember the debate that happened this year, cost is a major thing, and in India, cost plays a major role in how you treat patients as well. But
for India, the cost for the SGLT2 and DPP4 and sulfonylurea all are same now.
Gee, I was going to say exactly that. That if I had the option of same cost, now that you have generic medications for DPP4 inhibitor, SGLT2 inhibitor, metformin, you have a triple combination which we don't have in Canada. Then I would prefer that triple combination to adding metformin or sulfonylurea or a pioglitazone, like the old combination that people used to use.
Very true. Thank you.
Bajaj sir, that brings me to one question which comes in my mind. Because Diabetes Canada is very active and innovative, I see many times. And what insights or strategies from the practice you do in Canada, if can be implemented in India, that can help particularly in regions like resource restricted settings like India, how and what they can be?
Gee, and I would agree with that, and also say we are more evidence-based as well, the guidelines from Diabetes Canada, and more practical in addition. For example, Diabetes Canada is the only society among the all different world societies to actually now endorse remission of type 2 diabetes as a potential for newly diagnosed type 2 diabetes as well. So remission of type 2 diabetes is basically achieving an A1C and getting to a better weight without diabetes medication. So by diet, exercise, and reducing calories. And I know that there are many in India, you have many tools, especially online, talking about remission of type 2 diabetes as well. Now, this is not achievable for everyone. Remission of type 2 diabetes is maybe for 5% or something of your population of diabetes that you have. But even for those 5%, it may be an option that the guidelines in Diabetes Canada do endorse as such and can be applicable to India, I think. The other thing I would say about Diabetes Canada guidelines is we have individualized approach to patient management with type 2 diabetes. So it's not like an algorithm. If you had an algorithm or a computer system, you can just go to a computer and the patient can type, oh, my age is this, what medication should I take? But it needs to, you need to take into consideration all the different individual factors, which include cost, of course, right? But then you have to also look at the cost of having a heart attack, the cost of having a stroke for a patient who may be the only breadwinner in their family as well. So those are the costs that need to be taken into consideration, and we need to think about when we talk about taking cheaper medications or older medications versus the newer medications, which can actually prevent those complications as well.
Thank you, sir.
Thank you. Yes. Thank you, Dr. Harpreet. First of all, let me thank you because your slides were really excellent. You covered each and every update from the ADA in very, very detail. And not only that, you also added your own perspective that how important it is and how do we see those recommendations or those changes which were discussed at the ADA. So many, many thanks on behalf of Diabetes India as well as Diabetes IDF Southeast Asia. And Bharat, as always, he is a wonderful
clinician, moderator. He is a very knowledgeable person. We are sorry to inform our viewers that Dr. Deena couldn't join today because of some emergency back home. But we have domain expert Dr. Bansi Sabu with us. Dr. Bansi sir, are you still with us, or so at least we can have a couple of inputs from you on what has been discussed on type 1 diabetes, especially now the world is talking about the screening of type 1 and the stages of type 1 diabetes, the role of teplizumab. This is something which we have seen at ADA. Now the people are talking about both the aspects, and they're talking that yes, it is a very good innovation which is going to help in certain way. At the same time, there is a divided society because there is a large gap between those who can afford and those who cannot afford. So availability of such a therapy and how we see. So do we have different set of guidelines for those who can afford and those who cannot afford? So these are the questions I think which were very, very relevantly discussed at the ADA 84th scientific session, and I think you are the most right person to give your perspective on that.
So thank you, Amit. Actually, since last 6 months, a lot of things were happening related to type 1 diabetes prevention. In ATTD also, this was the molecule which was discussed last year also in SPAD. And Italy is the first European country who started doing universal screening. As you know that North Europe is having very high incidence. And mostly in Europe now, what they have decided that at least all the sibling of a type 1 diabetes, they should be screened. And some of the countries are proactive to start the therapy also for those who have more than 2 autoantibody positivity to give the therapy for prevention of diabetes. Now coming to India, first I must inform everyone that we are having highest number of type 1 diabetes in children in the world. So at present we have 226,000 as per IDF 221 IDF data. 226,000 children below the age of 19. And we also have highest number of type 1 every year, which are added in this number, which is 24,000. So as far as treatment is concerned for prevention of diabetes, I think India may be a country which will be definitely required. And Sanofi is also thinking of bringing this molecule to India. Maybe in a year, we will find that it is available to our country too. Now, for screening, the problem is that even we are not doing autoantibodies test for all our type 1. Mostly it is clinical diagnosed, those who are presented with diabetic ketoacidosis and those who have, with the significant weight loss and all other typical symptoms of hyperglycemia considered to be type 1 diabetes. Now, C-peptide evaluation, people started doing it because it is cost effective. Autoantibody screening is still costing, it is almost like 2,500 if we do 2 autoantibody, GAD and ZNT8, or you do IA2, whichever autoantibody if you do. So that's a challenge for India. The care for type 1 diabetes itself is suboptimal in our country. Still, basal bolus and 4 times monitoring is not standard of care for many of Indian centers. Still, people prefer premix and not getting their patients who are checking their sugar 4 times, rather once in a day or once in an alternate day. That is completely insufficient. And this, because of this suboptimal care, many of our type 1 diabetes, they die within 20 years of the diagnosis, or maybe 25 or 30 years. So they develop a lot of complication. But we have 20% of our population who are very affording. So my request is at least those who can afford, we can do their autoantibody for their sibling, and we can also diagnose, and we can take these international guidelines in our clinical practice. And I think that will be the future. Probably by next year, when we will be having availability of this molecule, some of our patients may get definitely benefit of preventing diabetes for a few years by putting them. But this innovation itself, which is very interesting, today somebody may say that, a new molecule had come, which is just preventing diabetes for a year or two, what it is going to give the benefit. But I tell you, if something had come, which is like a autoimmune disease now can be prevented, even for today, it is come for only 1 year or 2 years. But I'm sure a time will come that other autoimmune disease will also be prevented, whether it's a rheumatoid arthritis or whether it's a autoimmune thyroiditis. So, a complete new era of preventing autoimmune disease had come, and maybe in a decade time, we will see a lot of autoimmune diseases will be prevented. This is what I am thinking of. From ADA, there were a lot of talks related to type 1 diabetes. It was not only on this preventive aspect regarding the automated insulin delivery device, which is now, because we had heard in US when 780Z was, which had come in market, they had put 78,000 type 1 patients on AID. That is Medtronic 780G in 1 year. That's in record time, number of type 1 diabetic patients. And the average time in range was more than 80% of the time. The 80%, that is what the data they had shown. There were papers also, and there were posters, as well as there were talk related to AID. The other thing was that if you go in industry area, exhibition area, what I could see, and I'm sure Amit, you will be remembering also, the most of the companies were either technology or some of the newer molecules which were there. These were the only companies who were there in industry. I could not see the DPP4 or the companies like glitazone and the companies who are making like sulfonylurea. We used to see the Merck, and we used to see Takeda and Merck and MSD and their booth also, but now this year we could not see. It shows that the trend is toward the GLP and dual antagonist. And now alternative therapy for type 1 diabetes also started increasingly used all over the world, whether it is a SGLT2 inhibitor or GLP1, but both in obese type 1 diabetes. Data of SGLT2 was also discussed for type 1 diabetes management, but still I don't think that it can be used in India because of the problem of most of our patients who are already suboptimally and controlled. If you put them on SGLT2, possibility of diabetic ketoacidosis is very high, euglycemic diabetic ketoacidosis. So I will not prefer for that. And other than that, type 1 diabetes, there was a talk on stem cell and cellular therapy also. So they were also discussed in the type 1 diabetes, and probably in the near future, we will see some good work is going on, and maybe in near future, we will see that type 1 diabetes, a cure for type 1 diabetes also. The ICODEC data for type 1 diabetes once in a week, already Bajaj was talking about the once in a week insulin, which is also getting approved in our country, maybe this year end. And the once in a week insulin may be very useful, particularly for type 1. I was also one of the investigators from India in type 1 diabetes for once in a week. We had used continuous glucose monitoring, Dexcom, and compared it with a once in a day long-acting insulin. So that has really changed. That number of pricks definitely decreased. But in type 1 diabetes, how it will be useful, because otherwise also he has to take bolus injection for 4 to 5. Only thing, the best example thing that he's taking once in a week. So at least basal part is taken care. The chances of diabetic ketoacidosis will be less in compared to the patient who is on once in a day. If he forgets the once in a day injection, the chances of decay are high. While this is a longer acting, so once in a week, but that type of data was not there. But that's also very exciting news for type 1 diabetes, that they will be having a long-acting basal insulin, which will be once in a week. We don't have the inhaled insulin at present, but that's a right combination. If we get the good inhaled insulin, which have good bioequivalence or bioavailability of insulin, then, once in a week, you are taking a long-acting insulin as a basal, and all bolus are taken care by inhaled insulin. So, he's like almost prick-free. A type 1 diabetes who has to take more than 5 or 6 shots in a day, rather now it's a once in a week, only one injection. So these are some of the things which were there. And I'm sure in near future in India also, we will have all of these things.
Thank you, Bansi sir, for sharing all the updates and summing up what has happened in the field of type 1 diabetes. And I think all the medical fraternity is very optimistic regarding this. Because development of the monoclonal antibody tacrolimus in itself is a major breakthrough. And as you all know, even JDRF has changed now their name. It is Breakthrough T1D. So now they are not anymore Juvenile Diabetes Research Foundation. So
but that's a really very important thing, because it's not the juvenile disease. It is type 2 disease, can happen not only the children
And,
or adolescents, but to even the adults also.
and development happening around the inhaled insulin. The inhaled 3 trial was presented at the AD, as you know, and it showed promising results with better bioavailability and better PPG control. And also, you know that there were many, as we already discussed, there were many updates regarding the use of oral therapies in people with type 1 diabetes. So, though they are not yet approved, but in near future, we may not be very far from using GLP-1 based therapies as well as SGLT2 inhibitors in people with type 1 diabetes. So, this is something which has been discussed, not yet approved, but it is something which is exciting and can help people with type 1 diabetes in achieving a better glycemic control. So, with this, sir, I think we have reached our time limit. And before I propose vote of thanks, I would like to inform everyone that till yesterday we had 4,000 registrations for this learning from the AD, and today Uma has informed me that the number of registration has close to 6,000. So that shows that this program is in very much demand, and I'm sure over the next few days, 4 to 5 days, when we are going to discuss multiple aspects like technology and the other aspects of the diabetes care, more and more people will log in and join us in getting the update from the ADA. So with this, I would like to thank once again Dr. Harpreet Bajaj, Dr. Deena, who tried her best and couldn't join because of some personal reasons, an emergency at back home, and Dr. Bharat Sabu, as usual, always narrating a very nice session. And thankful to Diabetes India, Dr. S.R. Ravin, Dr. Azad Khan, and Dr. Bansi Sabu for making this program happen. And thank you, RX team, for your support, and thanks to all the participants. See you again tomorrow evening at 8 p.m. With next update from the area. Thank you very much. Thank you, Dr. Harpreet.
Thank you, sir.
Thank you. Care for industry support. Thank you.
Yes, obviously, sir. And Uma, now it is over to you.
Thank you, sir. So thank you, everybody, for all those of you who have joined at this time of the day. Have a good rest of your day. Thank you.
Thank you. Bye-bye, Harpreet. Bye-bye.
Bye,
Thank you. Thank you, Bharat. Bye.
Thank you.